Dialogue with a Doctor, featuring Southwest Florida's leading physicians, hosted by Dr. Gregory Leach and Jim York.
Good evening and welcome to Dialogue with a Doctor. My name is Dr. Greg Leach. I'm with my co-host Jim York, and we're here this evening to talk to Dr. Phillips, Dr. Raymond Phillips, and we're going to be talking about heartburn. So I think I want to ask you first, heartburn is such kind of a misnomer. What is it?
Well, heartburn, everybody has a personal experience with it, and it's such a common entity. But heartburn per se is a circumstance where an individual will have burning in their chest, radiating up into the throat, and often accompanied by a sour or acid sensation. And for years, we used to just focus in on that symptom alone, and as a result, we neglected many, many other symptoms that were associated with this. But the formal name is called Gastroesophageal Reflux Disease, or GERD, which has almost everybody's heard of that now. But associated with heartburn are other symptoms where you might get the sensation of fluid coming up into your throat, or a sensation of an irritation of your throat, a clearing of the throat, a cough, hoarseness, sometimes even a persistent, lingering lump sensation in the middle of and the base of your throat. And these are all things that you see with gastroesophageal reflux disease. Now, and they occur as a result of acid in the stomach that normally stays within the stomach. It flows up into the esophagus and burns the esophagus. Now, typically, there's a valve that separates the esophagus from the stomach that opens to allow food to enter the stomach and closes, and that valve prevents material flowing upwards into the esophagus. But in some people, what can occur is you can get a circumstance where that valve doesn't function as well. And as a result, stomach contents, acid included, can flow up into the esophagus. Now, a lot of people underestimate the power of the stomach. It produces a tremendous amount of acid each day. The pH is 1 or 2, and neutrality, which is the pH of, say, milk, is like 7. And because it's a logarithmic scale, it's a tremendous amount of acid. The stomach is well designed to tolerate it. The esophagus is not. And that backwash of acid burns and gives you a burning sensation and will literally burn the esophagus. And if it comes up into the throat, it can actually cause a burning sensation as well, and even problems with aggravation of asthma, sinus infections. So there's a lot of other symptoms that you see in gastroesophageal reflux disease other than just heartburn. And so now a lot of people are getting more familiarity with it. And now, go ahead, Jim.
How many people in the population have it, and how are you treating it now versus 20 years ago?
Well, the number of people with heartburn and reflux disease is steadily increasing. With the growth of America, and literally the growth of America, with more people being heavier, that exacerbates that tendency to have reflux. And so more and more people are experiencing reflux. So 20-30% of the population will have reflux symptoms. But as far as the issue of treatment, there's many, many things you can do. Of course, everybody's attention turns to medicines, but there's lots that can be done in terms of individual modifications of diet or activity and timing of foods that make a big difference. For example, if you eat a very large meal, you tend to reflux more. And so naturally, if you eat a more modest-sized meal, there's less reflux. And so, as well, typically it takes 2 hours for your stomach to empty out. So if you eat late and go to bed early, what will happen is your stomach will not be emptied out, and there'll be a great tendency to have reflux. And when you lie down and no longer have gravity to help hold that fluid in your stomach, there'll be a tendency for you to have more reflux at nighttime while you're sleeping. So eating a smaller size, staying upright after a meal to allow gravity to help hold the material in your stomach, and then allowing sufficient time after the evening meal before you retire for the evening is important.
And how long a time is that?
Typically like 3 hours.
3 hours, okay.
Yeah, and almost 95% of people, their stomach will be empty after 3 hours' time, so that you can comfortably recline without risking reflux. But there are foods that will aggravate this, and everybody knows on an individual basis a particular food or spice or something that will provoke things. But in general, there are certain foods that are reliable as far as provoking this. Foods that taste good will provoke this. And the reason food that tastes good will provoke this is typically food that tastes really rich has a lot of fat in it. And fat relaxes this valve, it slows the emptying of the stomach, and those two things together really promote reflux. But other things, like alcohol relaxes the lower esophageal sphincter, that's the name of that valve. And chocolate will relax that valve. Interestingly, mints of various sort will also relax that valve. And by the way, to digress for a moment, that's the basis for taking a mint after an evening meal. And that was traditionally Middle Eastern culture.
Right.
People would take a mint at the end of a meal as a way of allowing a relaxation of that valve so you could do a gentle, discreet burp to express satisfaction with your meal. And so that was the basis for having after dinner mints and so forth. That's become incorporated into our culture. But all these things that you can do in terms of modifying the size, timing of the meal, and the particular components of the meal will make a big difference. But also, weight reduction helps, but that's a sort of a long-term goal. And for the short term, the things I just mentioned will make a difference. Now, in the 1970s, for the first time, we had effective medications to reducing acid production. Before that, the medications that we had available, like bicarbonate or antacids, simply neutralized acid. But the effect was short-lived, 10, 15 minutes.
Yeah, I can remember in medical school, they were doing surgery after surgery on ulcers, and Motrin came up, but the first acid-blocking agent came along as Tagamet, sorry.
Right, Tagamet.
And by the end of 1 year, hardly any surgery was being done.
It was just a dramatic change in the 1970s, 1976. First Tagamet, then Zantac, then Pepcid. These drugs, now all available over the counter, reduced acid production on a reliable basis. But in the 1990s, with the advent of Prilosec, and then subsequently other drugs, Protonix, Prevacid, Nexium, now Zegerid, now Prilosec is over the counter. It's so safe and effective. These medications are a whole different category that powerfully reduce acid production over a 24-hour period and give you much more prolonged relief as far as heartburn and other symptoms of reflux, much more so than Zantac or Pepcid or Tagamet did. As a result, people who have severe heartburn now have been on these medicines for many, many years. And as a result, it's raised concerns. Hey, if all these millions of people are on this medication or medications, what are there any potential long-term side effects? And we've been really paying more and more attention to this. And in the last several years, some long-term side effects have emerged associated with using this medication. One of which is the tendency to have a reduced bone density over time, called osteoporosis, where people might be a little more susceptible to fractures because, and we don't know, but we believe it's a change in the chemistry of absorption of calcium, because this is what these medications do. They reduce acid. That didn't remember in your high school chemistry. It changes how calcium is solubilized, and you don't absorb it as readily. And the consequences in the course of a day, you don't absorb calcium as efficiently or as effectively as you once did. And over the course of years, that could translate into reduced bone density.
I get a lot of questions about this from patients now because it's more publicized and I think maybe more exaggerated. So can you put that into perspective for us?
It is a risk, but it's a small risk, and it's a risk that occurs in the context of years and years of use, and so it's such a remote risk but people become very concerned about it. And in a proactive fashion, what can be done is trying to increase the amount of calcium in your diet, to emphasize foods that are more efficiently absorbed. In fact, your body's very efficient as far as absorbing calcium from your foods, much more so than in the form of supplements. And so now we're encouraging increased dairy products, in addition to various vegetables and so forth that are rich in calcium, as a way of sort of enhancing the amount of calcium in the diet and to try to sort of counteract this tendency. But the risk is low. It's very low. And for people who have severe reflux disease, hey, there's significant problems that occur with this.
It's not just a symptom, it causes problems.
Oh, yeah. And we're always focusing on things like heartburn, but that acid, as I said a moment ago, burns. And the response to that burn, that inflammation, is you can create scar tissue. And that scar tissue can narrow down the esophagus. And so many people will have the experience of food not going down smoothly or easily or getting hung up. And as a result, sometimes food will get actually stuck and in response to this buildup of scar tissue that occurs with reflux disease. And in the past, people would just say, oh, my hiatal hernia is acting up and so forth. But it's extremely common. You go to any big gathering, and you can always pluck these people out very easily. They're the ones that are still in the middle of their meal while everybody else is on the dessert, and they feel embarrassed and self-conscious about it, and you talk to them, oh, I'm doing just what my mother told me to do, chewing my food 25 times a day with each bite. But really, they've realized that unless they chew their food more thoroughly, cut up their food more completely, and moisten it, that food will get stuck. So they're very, very slow in terms of eating. And so that's one example of a sort of an adverse event that occurs with reflux.
And that's not much fun to have because you have to go unstick it.
No. If the food gets stuck in your esophagus, it's like a cork in a bottle, and it won't go down, it won't go up, and the esophagus, in a desperate effort to push it down, will increase the intensity of contractions. You'll start getting pest discomfort, and it can be alarming. And so it often becomes an emergency. So if people feel that sensation of food not going down easily, it needs to be addressed. And by seeing your physician, or seeing a gastroenterologist to address that further. But there's other things that happen with reflux disease. And that backwash of acid can literally burn the lining of the esophagus, burn it away, and the poor esophagus, under this onslaught of acid, it's developed a clever defense. It's in the circumstance where the esophagus literally gets burned away, it can develop a new lining that can resist acid more efficiently and more effectively, and a lining that looks just like the stomach. And so it's a clever defense. Fortunately, that doesn't happen that often because that particular change, it's called Barrett's esophagus, can predispose a person to develop cancer of the esophagus. And that's one of the concerns many people have with this, is that, oh, gee, I have reflux disease, I'm going to develop cancer of the esophagus. No, you're not. It's a rare risk. It's extremely small. Maybe only 10 people out of 100 people who have bad heartburn will develop that new lining called Barrett's esophagus, and maybe one of them out of 50 over the next 10 years might go on to develop.
If that patient has bad heartburn and they treat it, therefore they don't have heartburn while they're taking Prilosec, does that eliminate that risk of cancer?
No, and that was the thought in the 1990s, is that with the advent of Prilosec and these powerful new medications, that we can not only get rid of heartburn, but we can strike at this risk of cancer of the esophagus. And as it turns out, though, the risk of cancer of the esophagus, and I want to emphasize this point, is that you have heartburn, it leads to an injury or damage to the esophagus, and that only happens in 10% of people. And that damage can lead to a new lining called Barrett's esophagus. Those people that have that new lining, that Barrett's esophagus, maybe 1 in 50 of them might go on to develop a cancer of the esophagus. But the thought had been, oh, if we eliminate acid, perhaps that risk will go away. No, it won't. No, it won't. So what we've encouraged people to do is, if you have heartburn 3 times a week, yeah, you probably need to see a doctor to be checked over to make sure that you're not at risk for developing cancer of the esophagus. And if you don't have any sign of any development of this precondition called Barrett's esophagus, you probably never will develop it.
Well, we're going to take a quick break.
Okay.
And we're going to come back and talk more about heartburn in just a few minutes. We'll see you in a minute.
research as I could, and what I was looking for was a treatment that would give me the least risk of complications and side effects, and that's where the CyberKnife came into the picture.
Advanced CyberKnife technology, precise. It sends just the right dose of radiation to the cancerous areas, fast. Each treatment is only 1 hour, non-invasive. This outpatient procedure has almost no side effects.
The day after my treatment, I was out playing golf, and I'm looking forward now to continuing to enjoy a long and happy and comfortable life thanks to the care of my team of doctors and to the CyberKnife procedure.
Learn more about CyberKnife and Dr. Spellberg. Call today.
The survival rate for an early caught breast cancer is about 97%. Mammography saves lives by detecting that breast cancer early.
Radiology Regional Center, earning your trust yesterday, today, and tomorrow.
Radiology Regional Center is happy to bring you digital mammography. The advantages include shorter exam time, fewer retakes, and lower dose radiation. Radiology Regional Center, the best just got better.
You didn't do that.
Thanks.
Dr. Phillips, before we go into this more on the heartburn, could you just give us a little background of yourself and your practice there? I think
absolutely.
we missed that in there.
I'm a gastroenterologist. I'm a board-certified gastroenterologist, and what that means is, I went to college. I went to Princeton. I went to medical school at Washington University. I did training in internal medicine, Jefferson Hospital. I was chief resident. Since I'd gone through college on an ROTC scholarship, I went to the Army at that point, and I was an internist for 2 years, and then I did my gastroenterology training at Walter Reed, and then I was on staff at Walter Reed for 2 years. And then in 1991, when my obligation was complete with the Army, I came to Naples, and I began to practice here in Naples, and I've been here for the last 20 years with our practice, gastroenterology group of Naples. I practice with Dr. Lubersky, Dr. Randall, Dr. Michael Marks, Dr. Ahmed Khatib, and our office is on Goodlet Road, at 1064 Goodlet Road. But we also have offices in Bonita as well as Marco Island. But the point of emphasizing this is I'm an expert in gastroenterology, gastrointestinal illnesses, and today we've been talking about reflux disease and the basis of it, why it occurs, how to treat it. And we were just talking a moment ago about the issues in terms of potential risk for provoking inflammation in the esophagus that could lead to problems in terms of scar tissue, trouble swallowing, problems in terms of putting you at a slight risk for cancer of the esophagus. And that's been a great frustration, that last issue, because it frightens many people, but the risk is very, very low. And to put it in context, it's a very rare event, but it's received a lot of press, and in terms of, and so it alarms many people. But as far as allowing people a framework in terms of, hey, is this something I need to talk to my doctor? Hey, if you're having heartburn 2 or 3 times a week on a regular basis, if you're having to take antacids on a regular basis, if this is going on for month after month and not going away, yeah, you need to talk to your doctor about it. And he'll talk to you about, hey, whether you need to see a gastroenterologist about it. And you might say, well, what would they do? What would a gastroenterologist do? Is, often to determine how severe an issue it is, we'll do an examination of the esophagus, where we use a flexible endoscope and while you're sleeping to examine the esophagus and see if there's any sign of any damage or inflammation, and then guide therapy and gives us a sort of better framework in terms of how much therapy to use and how long to use it, in fact. But we were highlighting some of these medications earlier, and Greg was mentioning that in the 1970 course, in the 70s, we used Tagamet and Zantac. Those are available over the counter. Now these more potent medications like Prilosec are over the counter as well, but the rest of them, Protonix, Nexium, Acifex, Dexilant, Zegarit, they go on and on. Those require prescriptions. And they should, because we're learning there's some subtle side effects that can occur with those things, and we're learning, like many things in life, you need to use just what you need to control symptoms, but not more and not longer than when the symptoms are finally under control. A recent area of interest that has captured some of our ear, nose, and throat colleagues is the issue in terms of reflux up into the throat, where you get subtle symptoms like clearing of the throat, hoarseness, a lump in the throat, sinus infections, asthma, and that there has been a thought that using higher doses of medicines to reduce acidity will help treat that. And that's an area of difficulty right now because it's hard to diagnose and it's difficult to treat. And there's a lot of confounding issues. 80% of Floridians have allergies and often have postnasal drip and clearing of the throat. So it's often hard to sort of sort that out from other conditions that can give you similar sort of symptoms. But suffice to say, it's just there's many other symptoms other than just heartburn that we encounter in gastroesophageal reflux disease. The one thing, and it kind of keep coming back to this, not to emphasize this as very common, but it captures people's attention, is this issue of reflux disease as a potential cause for cancer of the esophagus. Again, the risk is extremely low, but there's a recent article in the last year that indicated that the medications that we use to treat reflux disease could cause cancer of the esophagus. And that was the interpretation of the article, the notion being that these medications could diminish the perception of reflux so it could continue unchecked and cause injury to the esophagus. And the article was not well done. It was not a perspective, that is to say, it didn't follow a group of people over a long period of time. It was retrospective. Hey, you looked at the records of these people, and it suggested there might be a slightly higher risk of people who were taking medicines for reflux, that there was a higher risk of cancer among those people. Well, they were taking the medicine for a particular reason, reflux. And we just talked about there is that association already. So it raised a lot of concerns, and based on a study that really needs to be confirmed. And so the point being, as I said a moment ago, is if you have symptoms that are severe and you need something to control it, use what you need to control it under the direction of your physician.
So hopefully that study won't spawn the 1-800 calls and to attorneys and everything.
Well, it doesn't take much to spawn calls like that.
Who gets scoped and who doesn't? Who gets looked at?
And that's an important question. And it's not like, gee, I went out and had pizza last week and got some heartburn, and I better go see my doctor. Everybody gets heartburn or reflux at some point in their life when you eat a particularly rich meal. It's individuals that have repeated episodes of reflux or repeated episodes of heartburn, where it's occurring regularly 2 to 3 times a week, and you're having to use something on a regular basis to control it, and these symptoms are going on for months and months, 6 months, 12 months, then that really deserves attention. And what I mean by attention is specifically what you're saying is, hey, you see a gastroenterologist, they do an examination, and if there's no sign of any damage to the esophagus, well, that's great. Then the therapy then is directed toward controlling the symptoms, not to treat any kind of injury. And that's important. Yeah, if there's no sign of any injury, the goal is to relieve heartburn. And so you use the minimum amount of medication it takes to relieve that in conjunction with lifestyle modifications like we talked about before.
So do you scope the 20-year-old or the 60-year-old?
Well, there's a rare 20-year-old that has intractable heartburn that goes on day after day. And that's why I was giving you these time requirements. Yeah, a 20-year-old might do something crazy on a weekend and so forth, and they might get some bad heartburn. But it would be rare for a 20-year-old to have repeated days of heartburn going on for months and months. In that context, they probably need some attention, because there are some young adults that will have intractable heartburn, and oftentimes because they're young, they're ignored, and they feel like, well, gee, everybody has this, I'm not going to share this with anybody, and so oftentimes they don't come to the attention of a healthcare provider because of their youth and so forth. But the 60-year-old who's having those kind of symptoms deserves attention. Yeah.
What about, we don't need to talk about H. pylori, but my patients ask about this infection in the stomach that can cause heartburn, reflux, ulcers.
Well, Helicobacter pylori is a infection of the stomach. It was described in the early 1980s, and it was found to be the foundation of the majority of ulcers across the world. And but in societies where there's well-developed sewage and as well as water treatment, it has become less and less of an issue. Now it's rare to have Helicobacter pylori infection. It can sometimes masquerade like heartburn, and often when we do an endoscopy, we will check for that particular infection as well. But it's become a rarer and rarer phenomena, and as a result, less and less of an issue, and particularly in individuals less than the age of 60, less than the age of 50. So it's far, far rarer.
How about, we only have a couple minutes here left, how about people that have other medical issues? How does that affect having heartburn? And I know that's a broad question, but well, people have had transplants or
well, there's and that's an important question, because many of the medications that we have available now for us for treating, say, for example, asthma or hypertension, they cause a relaxation of this valve that I've been referring to a number of times, this lower esophageal valve. And when it's relaxed, it'll promote reflux up into the esophagus. So there are medications, many medications, that will do this. And so it's important for individuals to be alert. So they start a new medication, start having heartburn, they should talk to the doctor. Hey, is this provoking this? Do I need to take less? Can I use an alternative? And not just, hey, the doctor's prescribed this, I'm just going to keep on taking this, like he said, and just have a good conversation with your physician. Because medications can provoke this, and by modifying the medication or finding an alternative, and there are many effective alternatives now.
Right. Pretty much.
Well, we'd like to thank Dr. Phillips for coming tonight. We learned a lot more than we ever knew about heartburn, and we hope he comes back to Dialogue with the Doctor.
Thank you very much.
Well, thank you very much. Like I say, it's a burning issue of our time.